Preoperative evaluation for pulmonary surgery. So lung surgery are done very commonly, and there are various procedures which can be performed. So a wedge resection removes a small portion of the lobe, and a segment resection removes a small portion of the lobe, and lobectomy removes entire lobe, and pneumonectomy removes the entire lung. Are the common procedure. Now, assessment of the risk of the surgery is a tripartite risk assessment which considers the operative mortality, risk assessment of perioperative myocardial infarction, the risk assessment of postoperative dyspnea. So, risk assessment could be performed by the postoperative cardiac event with ACC, AHA's risk stratification and cardiology review. Perioperative death could be evaluated by Thoracotomy score, and the postoperative dyspnea, and the dynamic lung volume and transfer factor split lung function testing can be performed. So one has to address any potential modifiable risk factors and reassess the patient. And does the patient accept the risk for each category plus minus potential impact on the lifestyle? No. Then exclude the surgery for multimodality management, and if yes, offer the surgery as a part of multimodality management. So this is a model to estimate the risk of the death and have a high degree of discrimination within the applied population. As the in-hospital mortality rates are low, the large number of studies are required to develop these models. Risk stratification for the death in thoracic surgery is relatively rudimentary, and there is a large need of work that needs to be done to quantify. So Thoracotomy score is a good predictor of having population problems. The parameters which are discussed are age, sex, ASA stratification, performance status, severity of dyspnea scale, priority of surgery, extent of resection, diagnosis, and scoring. So, risk assessment of cardiovascular morbidity include the clinical assessment and risk stratification, optimizing medical therapy, and revascularization of the patient. So, these are the three important steps. And in the myocardial infarction is a major cause of mortality in non-cardiac surgery. The risk of cardiac death in non-fatal myocardial infarction associated with lung resection is generally 1.5% and is ranked as intermediate risk. The history, including the assessment of functional status, physical examination, resting ECG, and prerequisite for the cardiac risk assessment. All the patients with an audible murmur or unexplained dyspnea should also have an echocardiogram. The first step in the cardiac risk assessment is to identify the patient with active cardiac condition, as they require the evaluation by the cardiologist before surgery is to be done. In the patient who have no active cardiac condition, the risk assessment is performed using the revised cardiac index. The patient with two cardiac risk factors and a good cardiac function capacity with a flight of stairs without cardiac assessment with a functional capacity of 3, a risk factor should have a further investigation to screen the revised cardiac ischemia. So with the 3 or more factors with revised cardiac ischemias, for example, cardiac stress testing, therium scan, if necessary, cardiology review is necessary. So one should avoid the lung resection in 30 days of myocardial infarction, and we should need the cardiology review for these patients. 3 risk factors of poor cardiac functional capacity then offer further investigation to the patient with 2 risk factors and a good cardiac function capacity. Patients with coronary artery disease should have their medical therapy and secondary prophylaxis optimized according to the surgery. And it is advocated that the perioperative beta blockers, these result to a significant reduction in mortality or heart failure of the patient. So in non-fatal myocardial infarction and ischemia, if it is given, it has good results at the expense of increased risk of non-fatal strokes. It precipitates the withdrawal of ongoing beta blocker therapy is not recommended as may be hazardous. So the patient should have optimizing of the medical therapies, secondary prophylaxis and coronary disease should be optimized. Continue the anti-ischemic therapy in perioperative period, including the aspirin, statin and beta blockade. So revascularization is important. The thoracic surgery is found to have among the highest risk operation in the patient identified with suspected coronary artery disease in a non-randomized studies. The patient who has undergone previous coronary artery bypass surgery, the risk of death and myocardial infarction is observed to be reduced. The perioperative percutaneous coronary intervention is associated with a major risk of acute myocardial infarction and stent thrombosis. Should this patient require a prior thoracic surgery, the use of balloon angioplasty alone or a bare metal stent should be considered to avoid the dual antiplatelet therapy, aspirin and clopidogrel at the time of lung resection. So one need to discuss with the patient the need of coronary stent with the cardiologist to determine the preoperative antiplatelet management. Consider the patient with chronic and stable angina with conventional ACC-AHA indications for the treatment of coronary artery bypass grafting and percutaneous coronary intervention for revascularization prior to thoracic surgery. So the clinical assessment, advancing age increases the risk of surgery. Surgery for clinical stage 1 and 2 disease in patients with 70 years is equal to younger patient, and age over 80 is alone not a contraindication to lobectomy, and pneumonectomy is associated with higher mortality risk in LD. Assessment of lung function. The evaluation of lung function is a major important aspect in the preoperative assessment to estimate the risk of operative morbidity and mortality and the impact of lung resection on the quality of life, especially in relation to unacceptable post-resection dyspnea. So it is suggested that the FEV1 as a surrogate performance status rather than independent predictive factor for the perioperative death. So one has to do the lung volumes, transfer factor, split lung function and the exercise testing. So FEV1 is forced expiratory volume. One results given an absolute value in percentage predictor, and generally FEV1 of more than 3 liters in men and 2 liters in women. FEV1 falls in COPD and less than 50% predicted is indicative of severe disease, and less than 1 liter absolute is equal to very severe disease. PFR is used for more asthma. FEV1 FVC ratio is normally 0.7 to 1. FVC increases in COPD, decreases in restrictive lung disease. FEV1 FVC less than 0.7 is equal to obstructive lung disease. FEV1 FVC of more than 0.7 is equal to normal or restrictive lung disease. FEV1 may improve with bronchodilator therapy in COPD, but less dramatic than asthma, and many patients have ventilation. Both FeV1 and carbon monoxide transfer factor TLCO have been previously identified as an important predictor as postoperative morbidity and mortality and death. So it measures the lung carbon monoxide transfer factor in patient regardless of the spirometric values. Offer the surgical election to the patient with low risk of postoperative dyspnea, to the patient with high risk of postoperative dyspnea, and patient may need to be aware and accept the problem. So it measures the parenchymal lung function. PO2 of 60 millimeters of mercury and PCO2 of more than 45 were the old cutoff values but are still a warning sign. Diffusing capacity of the carbon monoxide corresponds to the functioning surface area of the alveolar capillary membrane interface, and predicted postoperative TLCO of 40% is associated with increased cardiac respiratory complication independent of FEV1. Pre-op TLC of less than 20% is relatively high. So for fitness of surgery, we do arterial blood gases, spirometry analysis in TLCO. Second stage is PPO, FEV1, PPO, DLCO, quantitative ventilation perfusion scan, quantitative CT scan, shuttle walk test, exercise testing, oxygen uptake, and VO. So first we perform ABG to see hypoxemia and hypercarbia, spirometry. If FEV1 is more than 0.6 liters for segmentectomy, FEV1 of 1.5 liters for lobectomy, FEV1 of 2 liters for pneumonectomy. TLC of less than 60% predicted is associated with increase. So split lung function is performed to predict the postoperative lung functioning. Different techniques have been used to predict the postoperative lung function, including spirometry, quantitative ventilation, perfusion, scintigraphy. So there are difficulties in interpreting the contribution of individual lobes to the overall ventilation of perfusion, and lack of additional information are compared with the segment counting alone, and patient being considered for a lobectomy. There is also a considerable uncertainty about the accuracy of the quantitative perfusion to predict the postoperative FEV1. However, the scintigraphy can be especially useful when an assessment has been suggested that there are further loss of lung function, and that would be unacceptable if it has shown that no further or minimal lung function would be lost by operating, and this applies where there are compression of the pulmonary artery or marked emphysema in the lobe containing the cancer. Where the ventilation perfusion scintigraphy can be used to predict the postoperative lung function, there is no additional benefit of performing the both. So this is ventilation perfusion scintigraphy, quantitative CT scanning, dynamic perfusion MRI, and SPECT scan. It is important to bear in mind that scintigraphy results may be underestimate the actual postoperative values. Although the quantitative CT scanning have been reported to be simpler and more accurate in prediction of the postoperative FEV1 in patients undergoing pulmonary resection, the dynamic perfusion MRI currently has the best reported test performance compared with the qualitative CT and perfusion SPECT, and may result in accurate and quantitative CT. So consider ventilation perfusion scintigraphy to predict the postoperative lung function, and ventilation perfusion mismatch if it is suspected. Consider using quantitative CT or MRI to predict the postoperative lung function if the facility is available. Cardiopulmonary exercise testing. It is performed to assist the predict surgical outcome and the range of cardiopulmonary exercises that are used, and this includes the assessment of exercise capacity such as walk test, stairs climbing, and the formal measurement of the cardiopulmonary function such as measurement of the peak oxygen consumption, that is VO2 max. 6 and 12 minutes walk test. Good performance on 6-minute walk test and stair climbing have been associated with improving surgical outcomes and have been reported to be similar predictor of mortality or the formal exercise testing in patients with chronic obstructive pulmonary disease and pulmonary hypertension. Distance traveled in 12 minutes was reported to be reliable approximation of the formal consumption of the VO2 max estimation. So in patients with COPD and more closely monitored 6, 4 and 2 minutes walk test, however the distance achieved on the 12-minute walk test has not been reported to be predictive complication after lung resection. Shuttle walk test. The shuttle walk test is a distance measured by walking 10 meters distance between the two cones placed that are progressively increased. This test has a good reducibility and associated with the formal cardiopulmonary exercise testing. So the recommendations are that the inability to walk 25 shuttles classifies the patient as high risk that have not been evaluated. So we're climbing these stairs, climb 3 flights of stairs for lobectomy and 5 flights of stairs for pneumonectomy, cardiopulmonary exercise testing, treadmill, cycling, VO2 max, less than 15 mg per kg indicates that the patient is high risk for surgery. Six meters walk, the distance patient can walk briskly on the flat surface. Pulse oximetry is monitored. It evaluates the global integrated response to the exercise of all the system involved without proving the specific information about the heart and lungs. Distance walked is usually compared to the matched controls, and desaturation is a bad prog sign. So, what we have discussed, we are going to summarize here the thoracotomy and respiratory assessment. It could be observed by lung mechanics, observing the parenchymal function of CP reserve. For lung mechanics, FEV1 and if it is PPO is less than 40%. Parenchymal function, TLCO, PPO less than 40%, or PO2 is less than 60%, and PCO2 more than 45, VO2 max less than 15. Stairs 6-minute walk test and exercise. So these all highlight that the patient has problems after this. So the post-thoracotomy anesthetic assessment predicted postoperative FEV1 if more than 40, patient can be extubated in operating room, and 30 to 40 consider extubation based on the exercise tolerance. TLCO VQ scan associated disease, and less than 30% stage weaning from the mechanical ventilator consider extubation in more than 20% plus thoracic epidrasthesia. So the formal testing includes the gold standard exercise lab, measure VO2 max, and 6-minute walk test, and estimated PPO VO2 max less than 10 millimeters per kg per minute may be absolute contraindication to pulmonary resection. Lung cancer is associated with most disruption to the quality of life compared with other chronic diseases or cancers, and the reduction may persist for more than 5 years. The physical domain of the quality of life deteriorates early after the lung resection surgery but improves to the near baseline in 6 months. Pneumonectomy, however, is associated with poor quality of life for longer duration as compared to lobectomy or bilobectomy. When pneumonectomy can be avoided, but there is a potential to increase the risk of recurrence, this should be explained to the patient so that they may make the choice. The traditional parameters used to assess the postoperative cardiorespiratory function do not correlate with the quality of life reported by the patient. Although it has been suggested that the quality of life after surgery may be related to the cardiopulmonary fitness, pulmonary function assessment alone is a poor predictor of the patient perception and physical disruption in day-to-day activities. Currently, it is thought that the respiratory symptom burden rather than ventilatory impairment contributes to the diminished quality of life, as discrepancies may exist between the patient perception about their residual physical and emotional status and objective functional measure. Lung function test and exercise test cannot be taken to the sole surrogates of the quality of life evaluation, and a quality of life instrument should always be used. Other identified risk factors for the postoperative quality of life include the postoperative dyspnea and administration of postoperative chemotherapy. The influence of the age is less clear, with some studies reporting that the elderly patients fail to make complete recovery, and some say that the different compared to the younger counterpart. The risk assessment should be done. So one should avoid pneumonectomy where possible by performing bronchoangioplastic resection for non-anatomical resection, and when estimating the quality of life, use a validated instrument. So the surgical approach, pulmonary resection, lymph node management, these are the steps of the surgery. So estimating the postoperative lung resection, bronchoplastic, angioplastic resection, sublobar resection, combined lung volume. So the postoperative FEV1 of more than 40%, PPO, DLC of more than 40, SaO2 of 90 is average risk. PPO of less than 40, PPO, DLC of less than 40 as high risk, and PPO FEV1 is equal to pre-op FEV1 into 19 segments to be removed divided by 19. So the postoperative lung function is estimated as a method of segment counting. The total number of segments are 19. The total number of obstructed segments are measured by imaging, subtracted from the 19 to obtain the number of functioning segments. The functioning segments to be resected, the number of segments to be resected is the right upper lobe is 3 by 4 and middle lobe 2 by 4 and right lower lobe 5 by 4 and left upper lobe is 5 by 4. The predicted postoperative lung function is then estimated by PPO value. It is important to recognize that the ability to perform the segmental and bronchoplastic resection allows the fewer segments to be resected and may allow the surgery offered to the patient who would not tolerate to the lobectomy. For example, the lung parenchymal sparing surgery can be considered for the patient with the tumor in the left upper lobe and extend into the apical segment of the lower lobe and performing the left upper lobectomy and the lower apical segmentectomy. Employ the segment counting to estimate the postoperative lung function as a part of the risk assessment for the postoperative dyspnea. Consider the patient with moderate to high risk of postoperative dyspnea for the lung parenchymal surgery. Bronchoplastic resection refers to the resection including the main bronchus or the bronchus intermedius, usually with a complete ring of the airway and continuity restored by the reanastomosis proximal or distal airway. Angiographic resection refers to the resection that involves the main pulmonary artery and continuity is restored by end-to-end anastomosis and reconstruction. The bronchoplastic resection is usually used in the setting of the low-grade airway tumors such as atypical carcinoid, bronchial sleeve resection to spare the lung parenchyma. For example, in setting of the lung cancer, avoid pneumonectomy, sleeve lobectomy. Low mortality and the lower lobe recurrence rates have been reported in the series comparing to the outcomes of sleeve lobectomy and pneumonectomy. Angioplastic resections are usually employed in the settings of the lung parenchymal sparing surgery. While there may be technical advantages to the lung parenchymal sparing surgery, the use of the range of procedures is generally common and may be technically challenging. So one need to consider the bronchoangioplastic procedures in suitable patients to preserve the pulmonary function. Sublobar resections generally refers to the wedge resections and segmental resections, and they are usually performed as an alternative to lobectomy in the patient with peripheral tumors with the limited pulmonary reserve. Wedge resection entails the macroscopic clearance of the tumor with surrounding margin of the lung tissue and does not follow the anatomical boundaries, where the segmental resection involves the division of the vessels and bronchi to the distinct anatomical segment. Segmental resection removes the draining lymphatics and the veins and might therefore result in low recurrence rate, although there is no evidence for the segmental resection may not always be technically feasible, but is studied in the left upper lobe lingula, apico-posterior anterior segments, and the apical segments of the both lower lobe and the sublobar resection for the patient with multiple foci of bronchoalveolar carcinoma. So consider the patient with limited pulmonary reserve for sublobar resection as acceptable alternative to lobectomy. It has been shown that combined lung volume reduction surgery improves the lung function after the surgical resection in patient with severe heterogeneous emphysema. The risk assessment to the post-treatment dyspnea FEV1 post-expiratory volume 1 lung volume reduction surgery projected postoperative TLCO and the transfer factor and the PP1 is analyzed. If the lung cancer is associated to the area with heterogeneous emphysema, it is reasonable to be used as a criteria for currently used lung volume reduction surgery. Preoperative FEV1 or TLCO more than 20% predicted to selected patient for the lung reduction. Potential benefit should be improved in symptoms due to the emphysema and curative resection. Consider patient with concomitant lung surgery with severe heterogeneous emphysema for the lung resection based on the lung volume reduction surgery criteria. Intuitive surgeons should be moving towards increasing accuracy of the cancer staging by systemic nodal dissection. However, there is a considerable variation in practice from no lymph node sampling, though the lobe-specific sampling to the segmental nodal resection. The postoperative morbidity is usually cited against the use of the routine systemic nodal dissection, and in response to this, the results of the American trials confirm the patient's randomized to the complete mediastinal lymphadenectomy that has little added morbidity as compared to those who underwent the lymph node sampling. The recommendations are perform systemic nodal dissection all the patients undergoing resection for the lung cancer and remove and sample a minimum of 6 lymph node or stations. So mortality rate pneumonectomy 6.8%, bilobectomy 4.4%, lobectomy 3.9%, and lesser resection 0.4%. Thank you.